So I've been asked to talk about severe acute pancreatitis, which if you are anything like me, you'd be slightly nervous about, because it's a condition that you know is problematic, difficult to treat, and it's not always entirely clear what to do and when to do things. And so I'm hoping that today I will be able to shed a little bit of light on some of these questions. The talk is more sort of clinically orientated rather than a systematic review of all the literature. That said, I will give you some references at the end for two recent systematic reviews that I personally have found very helpful. So the idea would be basically today, in the next half an hour or so, maybe a little bit less, to just familiarize ourselves with actually what is severe acute pancreatitis, which is the kind of pancreatitis we would, as intensive care doctors, have most contact with. A little bit about its epidemiology and its etiology. How do we make the diagnosis? How do we assess the severity? And then what are the treatment options? For me, often the surgeons, the radiologists, all these guys seem to just put their hand in a bag and pull out some test, and then that gets done. There doesn't always seem to be a lot of logic to what they do. And also, what do we do about antibiotics? So pancreatitis can roughly be divided into sort of mild and severe. There is a bit in the middle, obviously, but we won't go into that in too much detail. Essentially, if you have the signs and symptoms of pancreatitis, and on imaging you have no sort of parenchymal destruction or necrosis, you're dealing with a mild case, and mostly those guys will be on the wards. If you have organ failure, if you have local complications of pancreatitis, if you have Ranson criteria, more or at least 3 Ranson criteria, sometimes people talk about a Apache score more than 8, then you are dealing with severe acute pancreatitis. And this is usually where we, as ICU doctors, need to step up to the plate and bat. So to me, it makes sense to just very briefly look at, when I say local complications, what do I mean? And effectively here, we're talking about necrosis, pseudocyst, or an abscess. And I think it's important to distinguish between those. When you meet the patient, in my mind, one of the first things to do is to understand whether there are any local complications already, and what the sort of timelines to those are, and which ones they are. When people talk about necrosis, you basically refer to pancreatic tissue that's non-viable. So it's destruction of the pancreas and the pancreatic tissue itself. Usually it starts off being sterile, as you would expect. And if your case is limited to sterile necrosis, then the mortality rates are in the order of 10% is what is quoted. Quite a big proportion of patients who develop necrosis become infected. And so figures of up to 70% have been quoted. And suddenly, once you have you introduce infection, or infection becomes an issue, the mortality rate goes up to 25%. So if you talk about a pseudocyst, then you're essentially talking about a collection of pancreatic juices, which forms because of leaks from the pancreatic duct. And that can be in the pancreas or in the sort of immediate tissues around the pancreas, and it's enclosed by fibrous granulated tissues. And finally, abscess is essentially what we all know. It's pus. It's intra-abdominal, and it usually follows infection or necrosis of tissue. At some point, it becomes pussy, but it takes a long time to evolve. And people talk about 4 to 6 weeks. So it's not the kind of thing, if you see pus up front, then you have to think about whether there's something else also going on. So the most, as you would know, the most common cause of pancreatitis is heavy alcohol use. which, as you would expect, is more common in men. The second most common cause is gallstones, which are more common in women. In about 20% of patients or cases, you don't find a clear cause. And there are other reasons like trauma, hypercalcemia, hypertriglyceridemia, sorry, I can't say that, get my tongue around that, and also complications of ERPC or surgery. But I think if you can't find a cause, you need to think about maybe sending the patient to a specialist center. There are, for example, in the UK, a number of specialist centers for looking after patients with pancreatitis. How do you diagnose it? Well, it's I think we're all reasonably familiar with this. You get severe abdominal pain. It radiates to the back. You may or may not have nausea and vomiting. Other things to consider are the obvious, like cholecystitis, perforated ulcers, gut ischemia, obstruction. But by and large, if you have two of three, which involves abdominal pain, but that's consistent with acute severe pancreatitis, you have serum amylase or lipase that are more than 3 times the upper limit of normal, and you have characteristic findings on imaging. 2 of those three are usually sufficient to give you the diagnosis. A few things to keep in mind in terms of amylase and lipase. It goes up in other things, and that goes wrong in your GI tract as well. A very high value, very high amylase doesn't mean to say you have really bad pancreatitis and vice versa. And the fact that the amylase or the lipase are getting better doesn't mean to say the patient's getting better or the pancreatitis is getting better. If you have abnormal other liver functions, and particularly AST that is up, think about the biliary tract as a cause. And also don't be caught out by calcium, because calcium can be seriously low in the height of pancreatitis. So the fact that it's low or normal doesn't mean to say hypercalcemia can't be the cause. So imaging is an important part of the management of pancreatitis. And there are a few modalities. Ultrasound, essentially everybody with suspected pancreatitis should have an ultrasound, A, because it can help you diagnose gallstones, but B, it can also identify easily identifiable other causes. If you're not sure about the diagnosis, or if the patient's not better after 2 or 3 days, then you would go for contrast-enhanced CT or even MRI. So ultrasound first. If they don't get better or you don't have a diagnosis, go for contrast-enhanced CT or an MRI. The CT will help you eliminate other things. It'll help you delineate the complications, so it'll show you whether there's a pseudocyst, whether there is necrosis, and it'll also you can use it later on potentially to guide a fine needle aspiration to try and diagnose the presence of infected necrosis. If your MRI is pretty good at helping you diagnose pseudocysts and just to differentiate between uncomplicated pseudocysts and necrotic sort of stuff around the pancreas, and an MRCP or an endoscopic ultrasound, again, can help you detect small bile duct stones that was missed by ultrasound. Here are a few pictures, so you can see, do I have a pointer? So you can see where the arrows are. This is the pancreas here, and it's a contrast-enhanced CT, so you can see it's a bit swollen, but generally there's good sort of spread of contrast around throughout the pancreas, and so you would probably call that acute or a mild pancreatitis. Here you have the pancreas. Again, it's quite big. You can see these areas where there's no contrast, and so that would be area where necrosis are beginning to form. Here you have a cyst Again, I'm not a radiologist, so I'm dependent on my radiology colleagues for interpreting these results. Here you have an abscess, and you can see here you have gas in that amongst the dark tissue there, where the necrotic tissue. So these are some of the images that you'll be presented with, and to try and help you understand, is there a pseudocyst? Is there what is the extent of the involvement or the necrosis? Is there necrosis? And is there potentially an infection going on within the necrosis? You can use the diagnostic, the CT scan results to get some idea of the severity of the pancreatitis. And I won't walk you through the slide. Again, you can look up this reference here. It'll talk you through. But if you look at anything, the range being from normal to more than 2 peripancreatic collections or air, then you award various amounts of points. And if you have, people say that if you have more or equal than 7 points, then you are dealing with acute severe pancreatitis. The Ranson score, I think we're all familiar with, and so I won't spend too much time on here, other than just to make the point again that you have to wait 48 hours before you can actually complete. And so it doesn't always help you up front when you really need to make a diagnosis. A few other things, as I mentioned, people have mentioned Apache scores of more than 8, and you can use, it's proposed the sort of daily Apache score to track the severity over time. Other potential factors that may imply more severe forms are overweight individuals with BMI more than 30, old age. CRP more than 150 has also been associated with a severe attack, and you can use it to track the sort of progress over time. But then we all understand the problems with C-reactive protein, and it doesn't always, it's not specific enough to help with a specific condition. There's been there's interest in some other factors like, I've got them there, I won't talk you through them, but so far none of these have really made it into practice, at least not in our practice. So in terms of treatments, broadly speaking, you would group the sort of treatment options in terms of the general measures that we are involved with. The issue of nutrition exercise the minds of many people. How to deal with or how to try and prevent infection in the context of necrosis. What is the place of endoscopic procedures, and what is the place of surgery? So I'll just walk through these one by one. So in terms of general measures, if there is any, and this is very much stating the obvious to the audience, but if there is any sign of organ dysfunction or failure, patient belongs in the ICU. These patients do not belong, should not be on wards. The treatment initially is supportive. Fluid resuscitation is quite important, and these patients can be like other sepsis patients. Not that I'm saying pancreatitis is the same as sepsis, but then it's not unknown that patients with pancreatitis have ended up in sepsis trials. But they need quite aggressive fluid resuscitation. People talk about Ringer's lactate. I'm not sure whether that is actually the sole answer, or whether any fluid rather than no fluid is the way forward. But I think don't underestimate the fluid deficit. And pain relief is important. And it's important for these patients to be treated in a kind of a multidisciplinary approach. You need the radiologists on board. You need your gastroenterologists there. You need the surgeons to be involved. You need pathologists to be involved. And of course, you need yourself to be involved to coordinate and make collectively sensible decisions. And I think, as I said earlier on, if you have a patient where the case is not entirely clear what the cause is, that's probably the one that you should refer to your local specialist center. In terms of nutrition, and even in our institution where we see a reasonable number of these patients, this still leads to some anxiety. But mostly we manage to feed these patients enterally. The data suggests that it's safe, it's feasible, there's a reduced incidence of infection, it's less expensive, and you should reserve intravenous feeding, parenteral feeding, for those guys who are not tolerating enteral feed, or where you just cannot for the life of you get close to their calorie requirements. Those are the ones where you would supplement their nutrition with via intravenous routes. But generally, go for enteral. It doesn't really matter whether you go for nasogastric, nasojejunal. It's just use that route and try and convince the surgeons and your gastroenterologists to sign up for that as well. They don't always stand in line. In terms of infection, now, if you have necrosis, as I mentioned, then 40 to 70% of these patients develop infected necrosis. And usually this takes about 10 days after the onset of pancreatitis. So there is clearly a delay, or a window during which potential infections or necrosis develops, and then it becomes infected. And so the idea is to, what people have been talking about in the past is to see, can you prevent this, or if it's there, how do you treat it? Selective decontamination of the gut has been proposed, but it remains, this is to prevent, and it remains unproven. And basically you're left with the choice of antibiotics, do I or don't I? The guidelines or the evidence suggests that you should, if the patient has other non-pancreatic or extra-pancreatic infections, you should treat that. That is fairly obvious. So if they have a pneumonia or they have some other GI infection or any other infection for that matter, then treat that. And these patients, our data suggests that these patients, even with the best of will, where you don't want to give antibiotics for pancreatitis or necrosis, they still get antibiotics for other things. The second thing is and the evidence supports this reasonably strongly, is to not routinely provide prophylactic antibiotics. So you wait to see whether the patient actually develops infected necrosis. But if you do find that there is necrosis in or around the pancreas, and the patient does not improve by the time they have, by sort of 7 to 10 days, you can then do one of two things. You can either do a CT-guided fine needle aspiration to get samples, get it gram stained, and get your lab can tell you whether there's infection in there and what bugs there are and what it's sensitive to. Or you can empirically treat with antibiotics, and generally you're looking for antibiotics that will penetrate tissues, and particularly the pancreas. And the carbapenems, the quinolones, metronidazole are those sort of antibiotics. Mostly we use meropenem as our antibiotic of choice. And then finally, it's been mentioned that or been suggested that sometimes there may be a higher incidence of sort of fungal infections in this context. But again, the evidence is not that great, and it's the guidelines or the recommendations are that you do not routinely treat with antifungals, unless, of course, there's another, as I mentioned, specific reason. You find a fungus in somewhere where it shouldn't be. What is the role for ERCP? So ERCP, yes, if you have acute cholangitis. No, in most cases where patients have, if you have gallstones with acute cholangitis. Most patients with gallstones, if they don't have cholangitis or jaundice, don't need an ERCP, and an MRCP or an endoscopic ultrasound may be better to do. And just incidentally, if you have a high-risk patient, it makes sense to try and prevent post-ERCP pancreatitis. Sometimes people will put in duct stents and use non-steroidals rectally to do so. The mechanism of that, I must admit, I'm not entirely clear of. In terms of surgery, if you have mild pancreatitis due to gallstones, then at some point, once the patient's better, but before they go home, they have a cholecystectomy. If you have necrotizing pancreatitis due to a biliary cause, then you would again delay a cholecystectomy because you want the infection and the inflammation to settle down and for the sort of stuff and the collections to begin to organize and to stabilize before the surgeon go in there. If you have an asymptomatic pseudocyst or you have asymptomatic necrosis, then essentially you don't need to do anything surgically. You just wait and sit it out. If you have infected necrosis, again, there are two directions. One is if the patient's stable, you wait. And you can wait 4 weeks until you ask your surgeons to do anything. If the patient's symptomatic, in other words, they have ongoing symptoms, they don't improve, then you would do a necrosectomy. And again, the guidelines are to use minimally invasive procedures rather than doing open laparotomies. So I guess for me, the takeaway message there is that you kind of wait as long as possible before you do anything. And when you do something, you do as little of it as you possibly can. A few things have been tried in the past, and it's not been shown to improve outcomes. These include resting the pancreas, which again to me never really made sort of mechanistic sense. Reducing enzyme secretion, countering the effects of the enzymes, and doing peritoneal lavage. None of these are recommended currently, and so yeah, that's all I would say about that. In terms of prognosis, half the deaths occur early within 2 weeks, and mostly these are due to systemic inflammation, organ failure. Late deaths are usually a function of infected necrosis. And those who survive have lots of exo and endocrine deficits. Many of them end up being diabetic. You have pancreatic duct strictures and leaks, a whole array, recurrent pseudocysts. And so this is a complex problem that will have long tail problems for the patient. Finally, and this is very close to the end, I can recommend these two guidelines, these two papers. This by Scott Tanner and colleagues published last year summarizes the latest evidence and the recommendations behind the evidence behind the latest recommendations. And this is also a very good overview of severe acute pancreatitis published in JAMA in 2004. So I would recommend you read that. I find those very very helpful. So in conclusion, these patients need general support. If they have organ dysfunction, they need to be in the ICU. If you have any concerns, they need to be in the ICU. They need analgesia. They need a lot of fluid resuscitation. They need aggressive fluid resuscitation. And I would say, in my own practice, that means the way we usually resuscitate people in the ICU against the endpoints that we are familiar with. We need to understand whether they have cholangitis, because that will put us down a specific treatment track. And we also need to know whether they have local complications, because A, that gives us a sense of severity, but also potentially where we are in timeline and what we may need to do down the line. Enteral feeding is preferable. Don't be pushed into parenteral feeding. You can confidently quote the literature on that one. Antibiotics, I guess, don't treat pancreatitis routinely, or don't use prophylaxis routinely for pancreatitis. Treat other infections, obviously. And if you have a patient with necrosis where there is no improvement after 7 to 10 days, then carbapenems would be a good way to go. If you're going to do surgery, as I said earlier, wait as long as you can and do as little of it as you can, meaning as minimally invasive as possible. And that's it. Thanks for listening.